Hello everyone, this is our series of arthritis and its related diseases. So in this video I am going to teach about rheumatoid arthritis. That is a very important topic for a university exam in orthopedics. Okay, rheumatoid arthritis is a disease of synovium. It is a chronic non-suppurative inflammation of the synovial joint. Uh, Now you have to know about the synovial joint, the joint between the bones which is filled with the fluid, so it causes a chronic non-suppurative inflammation. Synovial joint are the hip joint, shoulder joint, acrocomion joint. Okay, so you have to know this. Now we can discuss the etiology of rheumatoid arthritis. First is the genetic factor and the agent. The genetic factor are the histocompatibility marker associated with this disease, the HLA, DRW4, HLA, DR1. These are the markers. And agent mycoplasma, clostridium, and some viruses, that is Epstein-Barr virus, which is involved in this disease. This lead to a autoimmunity and formation of an immunocomplex with IgM antibodies in the serum. These immunocomplex are deposited in the synovial membrane and initiate a cell-penetrating chronic granulomatous inflammation of the synovial membrane. Basically, a rheumatoid arthritis is a disease of autoimmunity disease in which autoimmune antibodies are formed which act on its own self. Now we can learn the pathology of rheumatoid arthritis. I'm going to show the flowchart. You can easily remember this. Initially, after the etiology, the inflammation is occur in the synovial cavity. Now, initially synovium become edematous and filled with a fibrin exudative and cellular infiltrate. This will increase the synovial fluid, and after the persistence of inflammation, the synovium get hypertrophied and surround the periphery of articular cartilage to form a pannus. Pannus, which is defined as a extend over the cartilage from the periphery and burrow into the subchondral bones. After the articular cartilage loses its smooth, shiny appearance. If the disease is progress, that will lead to a cartilaginous bone surface become raw. Joint get deformed. Joint will get deformed because of two reasons. Initially, due to severe muscle spasms associated with pain, and another is after later due to fibrosis of capsule and other soft tissue structure. Okay. In some cases, pannus leading to a fibrous ankylosing, bony ankylosing, in advanced conditions of subluxation of joint, osteoporosis develop in bone adjacent to the diseased joint, and pre-articular tissue, notably tendon and muscle, become edematous and inflamed with cells and may rupture simultaneously. This is condition in some cases where disease become progress. Okay, now some of the course of the disease is how to course progress. In mild cases it totally recovers. In severe, deformities will get formed and patient may have a attack. Sometimes the physical exertion, psychological stress, infection, or occasionally a trauma. Here, stages of rheumatoid arthritis. From the clinical point of view, these are three stages. Potentially reversible soft tissue proliferation, which is defined as the limited to synovium and synovial hypertrophy and effusion. No destruction changes can be seen on X-rays, and Second is the controllable but reversible soft tissue destruction in early cartilage erosions. In this, the X-ray shows destruction in the joint spaces, but outline of the articular surface is maintained. In third, irreversible soft tissue and bony changes. In this, penis is destroyed, which become lead to a articular cartilage and erodes the subchondral bone. And joint become ankylosed, or maybe we can have fibrous ankylosis, or subluxated, or dislocated. Here I can show the how these are the form. The above 2 points I already explained. Now we can discuss the clinical feature of rheumatoid arthritis. Clinical feature mainly the age is a common factor. The 20 to 50 years of age is this rheumatoid arthritis seen. Sex in female is more common seen. The 3 times is more seen in female. First is an acute symmetrical polyarthritis. Pain and stiffness in a multiple joint, at least 4 joints may be present in morning particularly. Marks the beginning of disease and the articular inflammation, that is the symptoms of the disease progression which affected the joints. There are several joints involved in this condition. I am going to show the table which can you remember easily. Here you can see the joint affected in rheumatoid arthritis. The first, the common metacarpal pharyngeal joint of hand, proximal interpharyngeal joint of fingers, wrist, knees, elbows and ankles. Less common, hip joint, temporomandibular joint, and uncommon is atlantoaxial joint and facet joint of cervical. In other clinical feature, the fever that is unknown origin is seen in children, and visceral manifestation, that is pneumonitis and rheumatoid nodules. On examination, we are see the some of the deformities in rheumatoid arthritis. Here I can show you the pictures and table which can you easily remember. Here these are the deformities in rheumatoid arthritis. First in hand, you can see the ulnar drift of the hand, botanier deformity, swan neck deformity, and elbow flexion deformity, early flexion deformity, late tribal subluxation, ankle equinox deformity in foot, hallux, phalanx, hammer toe, etc. Here I can show you some pictures. Here you can see the ulnar deviation of hand and fingers. That is a botanoid deformity and swan neck. In swan neck deformity, you can see the PIP as well as DIP. In botanier, you can see only the PIP deformity. Hammertoe defect, hammertoe and hallux valgus. This you can remember as in rickets, the Janu bulgum and Janu valgus. You can easily remember this. Here, these are the extra articular manifestation of rheumatoid arthritis. First, the vasculitis, digital arthritis, Raynaud's phenomena, fever, skin lesions, chronic leg ulcers, peripheral neuritis, necrotizing arthritis involving coronary artery, mesenteric and renal vessels. Rheumatoid nodules, that is the most common site is olecranon, and it is an important feature of rheumatoid arthritis. Other side, dorsal surface of forearm and tendoclitis, serositis and others. You can see there, remember this easily. Now we are going to investigate the patient of rheumatoid arthritis. There are 3 to 4 methods: radiological examination, blood, synovial fluid examination, synovial biopsy. The first is the radiological examination. in which you can see the reduced joint spaces, erosion of articular margins, subchondrosis, juxta-articular rarefaction, deformities of the hand and fingers, soft tissue shadow at the level of the joint because of the joint effusion or synovial hypertrophy. Here I am going to show the radiological picture of the rheumatoid arthritis. Here you can see the features of uh, rheumatoid arthritis, that is a reduced joint spaces, erosion of articular margins, juxta-articular rarefactions, soft tissue shadow at the level of joint because of the joint effusion or synovial hypertrophy. In blood picture, you can see the elevated ESR, low level of hemoglobin value, rheumatoid factor. The immunoglobulin antibodies are seen, IgG, rheumatoid factor, IgM, Ig. Most common is the IgM, which are used for tests, that is lattice fixation test and Rose-Valley test. Lattice fixation test has a sensitivity of 80% and Rose-Valley test has a sensitivity of 60%. Synovial fluid examination and synovial biopsy are the investigation of choice of a rheumatoid arthritis. Here are the differential diagnosis of the rheumatoid arthritis, which we can differentiate from other diseases. The first is the SLE, systemic lupus erythematosus. In this, the disease, the SLE, that is a non-symmetrical of joint involvement. In rheumatoid arthritis, you can see the symmetrical joint involvement. If one joint is involved, the other hand of the joint is simultaneously involved. Nor ankylosis and erosion is not common, and here is absence of anti-nuclear antibody factor is in favor of rheumatoid arthritis. And although the presence of this anti-nuclear antibody is not confirmed of SLE, but in the 25% cases, the low titer of this value ANF is found in a rheumatoid arthritis. Another two differential diagnoses are the osteoarthritis and psoriatic arthropathy. In osteoarthritis, this is seen in older patients, complete lack of systemic features like found in a rheumatoid arthritis, that is a fever, weight loss, fatigue, etc. Here the distal interphalangeal joint often involved duration of morning stiffness, joint swelling, ESR. Here these are less compared to rheumatoid arthritis. These all features are here is less found in a rheumatoid arthritis. In osteoarthritis are common. Okay. Now in the psoriatic arthropathy, skin and glaze lesion present, DIP involved, rheumatic factor is here is negative. Now how to going to treat the patient of rheumatoid arthritis? The mainly the three principal basis of the treatment. First, the induction of remission and its maintenance. Here the disease are controlled by the drugs, preservation of joint functions and deformities. This is done by the physiotherapy and splinting management, and the repair of joint damage which already exists. The surgical interventions are the process which if the disease is damage is severe, the synovectomy is done. The above mentioned these above goals are under divided into two parts, that is medical treatment and orthopedic treatment. In medical treatment, we are going to give the drugs like non-steroidal anti-inflammatory drugs, drug induced disease induced modified anti-inflammatory disease modifying anti-rheumatic drug, and the third is the steroids. And these all drugs are given in the medicine textbook. You can learn this on the medicine textbook. which is very important in the view of medicine. Another method that is orthopedic treatment. Here the two methods are involved: non-operative and operative. In non-operative method, physiotherapy. In physiotherapy, splintage, heat therapy, joint mobilization exercises, muscles building exercises, occupational therapy, rehabilitations. In rehabilitations, the devices are used as braces, walking aids, etc. In operative method, uh, preventive surgeries, palliative surgeries, reconstructive surgeries, and salvage surgeries are used. Management, in this the plan of treatment, how to treat the before we treatment the management are given. We are going to see the three stages of rheumatoid arthritis. So on this we manage the patient. There are three stages given: potentially reversible soft tissue proliferation, controllable but irreversible soft tissue destruction, advanced stage of joint destruction with subluxation or dislocation. In first stage, the tissue potentially reversible soft tissue proliferation, where drug therapy constitutes the mainstay of the here the only the mainstay of treatment is the drug therapy. Second stage, controllable but reversible soft tissue destruction and early cartilage erosion, where a combination of drug therapy and orthopedic treatment is required. Here, drug therapy and orthopedic treatment are required. In advanced stages of joint destruction with subluxation or dislocation, where primary surgical treatment is necessary, that is surgical treatment here is necessary, here this necessary, here this and this necessary. The drug alone are no use of this at these stages. So here guys, our topic rheumatoid arthritis is completed. If you want my notes, then you can join the Telegram channel and you get that. Or if you like my video, please like, share and subscribe this channel to more videos and updates. Thank you guys.